Brought to you by Patient Advocacy Group, the Global PAD Association at padhelp.org, in partnership with Reflow Medical, the pulse of medical ingenuity. Here are your hosts for the Heart of Innovation, Emmy Award-winning journalist and founder of the Global PAD Association, Kym McNicholas, and interventional cardiologist and founder of Save My Piggies Health and Wellness, Dr. John Phillips.
Hi, everyone. Hello, hello. Welcome to the show. Dr. Phillips has the day off to go save those piggies. And today we have vascular registered technologist Jill Sommerset, who is the Global PAD Association's Diagnostic Innovative Champion for 2024. We absolutely love her and everything she's doing to help patients and innovate around peripheral artery disease, which is that poor circulation and mainly the legs. We're going to get into how her innovative approach to measuring blood flow in the smallest arteries in the feet is helping a general surgeon in El Salvador reduce diabetic amputations that are related to poor circulation, again known as peripheral artery disease or PAD. Dr. Fernando Javier Martínez Irigoyen is going to be joining us to talk about how his nation, with about 12.5% of the adult population struggling with diabetes, he is trying to help these patients, and he is going to share his plight to save life and limb. So excited about this show. First, I want to welcome Jill, my guest co-host for the day. Thank you so much for being here.
Well, thank you, Kym. It's really nice to be here. You know, we just saw each other a couple of weeks ago at NCBH, and I was commending you on all the amazing work that you do. You're such an incredible patient advocate. And then I realized, oh my gosh, I need to connect all of us with my friend and really incredible general surgeon, Dr. Irigoyen in El Salvador. And I just thought this would be a really delightful conversation to really share the incredible work that he's doing and to share the story of our friendship and how he's implemented this technique called pedal acceleration time, which is ultrasound of these small little arteries in the foot. And we can determine what the perfusion is like in the foot. So with that, I'm so excited to introduce Dr. Fernando.
Hi, Dr. Fernando, all the way from El Salvador. Thank you so much for joining us.
No, thank Kym and thank Jill for the invitation. For me, it's a pleasure to be with you and try to share with all of you the work that we are doing in El Salvador, trying to avoid a major amputation in our diabetic patients.
Yeah, well, I'm excited to get into this conversation. Go ahead, Jill.
Well, yeah, I thought it would just be really nice for Dr. Fernando to talk about how actually we met over the pandemic. I think it's a really lovely story. So I'm just going to turn it over to him and share that journey that we've had together.
Yeah, it's kind of be funny because during the pandemic, we cannot able to fly to see other people in person. So I started looking in the social media, what to read, what to do, what to learn more for my career. And in Twitter, many years ago, because now it's X, and that time called Twitter, I started looking for this research of PIT Doppler help in diabetic foot. So I start reading. So we have a friend in common that from Mexico that called Toño Muñoa. I write Toño and say, can I write Jill? Because I want to meet her and know more about the PIT Doppler. And Toño said to me, yeah, write to her. He's very available. Okay, I text Jill and I hope to get an answer. But the amazing thing that I have an answer in a very, very, very short time. And Jill texts me and say, do you have a WhatsApp? Can we talk? And when we talk, say, do you have time on Sunday? Yes. Okay, see you at Zoom meeting on Sunday. And that Sunday, we have a 2 hours masterclass with PIT Doppler with Jill. And that's how we start our friendships, and that's how I start doing the PIT Doppler with my patient.
That's pretty remarkable. I mean, what's really, I think, so incredible is that here's a doctor. I think it's great for patients who are watching and listening to to hear that this is a doctor that is continuing, not resting on his laurels and what he learned in medical school, but actually truly continuing to learn and grow and thinking about how can I do more for my patients? What were your struggles? What really kept you up at night that drove you to search for answers?
You know, here in El Salvador, 5 years ago, to evaluate our diabetic foot, we only perform the ABI, but right now, all know that the ABI in diabetic foot is not the best thing that to perform to know the vascular artery in the foot. So we changed and start doing the curve flow of the toes, and then we perform arterial plethysmography. But there are not so specific where is the trouble is. So that's why I start looking what to do more and best for my patient. That's why when I read and met Jill and see the pedal acceleration time, wow, it's amazing how the PIT Doppler can help to make a very good diagnostic on our diabetic foot and try to make a very good treatment to our patient, try to avoid a major amputation.
And just to recap with everyone, ankle brachial index is that test where we put blood pressure cuffs around the ankle and the arm, and we compare those blood pressure measurements. But they can be false or have a false reading in patients with diabetes or renal failure because those small little arteries are filled with calcium and the blood pressure cuff just can't get an accurate reading. And so I think this is where the PAT Doppler, which is ultrasound directly looking at those arteries in the foot, and we can measure the waveform and have an objective number that's not really, it's very reliable in the diabetic patient. And when we come back from break, I'm really interested to hear Dr. Irigoyen's application in his patient population, especially in patients with mixed venous disease.
And we'll be right back.
With me?
We still had a lot of time left, or at least one more minute.
Okay. Well, I just figured she tossed the break, so I just let her toss the break as my co-host.
Okay.
Sorry.
That's okay. That is totally fine. That was a really good toss to break. I was going to ask you if you wanted to do a couple tosses to break. And she was like, that's great. Good job. Hey, Christy, can we start out with a moment of inspiration?
Yeah, sure.
Do you want to kick it off right out of the break and then I'll talk?
Sure.
Okay. That worked out really well. That's such an interesting story. And thank you, Jill, for just, clarifying that. We'll do our moment of inspiration. I want to get into a little bit so people understand what is, the diabetic foot, how it relates to, when it crosses over into poor circulation and you have two different types. It is when you have the diabetic foot, you have issues more with the capillaries, right? When it's PAD, it's with the pedal loop, it's with the grander arteries in the foot and the calf.
Mm-hmm. And maybe you can talk through that, Fernando, just about maybe even the patient sitting in front of you with these complex diabetic foot wounds and how you evaluate them and your
30 seconds.
Thinking.
Okay. Yes. First of all,
hold on.
Okay.
We're going to come back from break first. Hold on.
For a free consultation and free credit review.
Isn't this fun?
Yes.
Here we go. For those at home, we're just waiting to come back from
9523
AM 1220 KDOW.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kym McNicholas and interventional cardiologist Dr. John Phillips.
Dr. John Phillips, spectacular vascular moment of inspiration.
This is obligatory. I mean, we have to do this every show, even if Dr. Phillips is out saving the piggies. Jill Sommerset, vascular technologist, or you know what? If we were in Europe, we'd be calling you a vascular scientist, right? So you're just amazing. Helping to change the world, create the change we all want to see in helping patients with peripheral artery disease, the poor circulation in the legs. But moment of inspiration, usually Dr. Phillips has a quote. And so I want to ask both of you, do you have a moment of inspiration that you can share with us in honor of Dr. John Phillips?
Well, go ahead.
No, ladies first.
Oh, I was going to say, Dr. Fernando and I all are WhatsApping all the time, and it's always amazing because he does amazing work in El Salvador. The limbs that he is saving is amazing. So that's my a moment of inspiration is it's amazing work.
So the words of inspiration, amazing. So that's going to be our word of the day. It'll be amazing. Why is this word important to you, Dr. Fernando?
For me, as a general surgeon, we love to be in the OR, making a big surgery and try to save lives. We supposed to think that we only save lives in the OR. But when we start treating diabetic foot and see the afraid of the face of our patient coming without no walking, and then you saw the patient return to your clinic walking by their own with a big smile, that is the best thing I ever saw in my patient when we save the foot in a diabetic patient.
And that is amazing.
Amazing, yes.
So before you met Jill, I want to go back to what was not so amazing for you and sent you on this journey to find answers for diabetic foot. Talk about the struggles that you have, explain diabetic foot, the different types, and what the biggest issue with diabetic foot is for surgeons like you.
Okay, we have a big trouble here in El Salvador because diabetic foot, we only offer a major amputation for most of our patients. So like 20 years ago, I started with this journey with the diabetic foot and try to save as much as we can. So that's why we've been looking for all the tools that we get to get better and better and try to avoid a major amputation. The way is, like a general surgeon, then I start doing phlebology. And in phlebology, it's mandatory that you have to perform our venous Doppler by our own. That's why I learned to do in Doppler. So to include the PIT Doppler to my practice, it was not so easy, but helped me a lot to know about the venous Doppler. And that I learned most of the PIT Doppler by Zoom. We, with the patient, we put a Zoom meeting with Jill, and Jill via Zoom told me all the tricks to perform the PIT Doppler to my patient. So that I think that is the amazing story because during the pandemic, we cannot go out. We've been meeting by Zoom all the time. I asked the patient if they can allow me to be in a Zoom with Jill, explain what I'm going to do. And when I start seeing that we can measure a very tiny artery on the foot and we can see where comes the trouble and to program a very good angioplastic to perform a better surgery in this patient. That's why I say the PIT Doppler for me right now, I perform all my patients that come to my clinic and to our hospital, we perform a PIT Doppler to perform the artery evaluation.
And just to recap with everyone, when we talk about PAT, which is pedal acceleration time, this is again ultrasound of the small arteries in the foot, and there's established criteria around this technique. So Dr. Fernando and I know, based on the criteria, how we measure the blood flow has 4 classification numbers. So class 1 and class 2 have pretty decent flow to a diabetic foot ulcer. If the waveform is abnormal and now you have a different class of PAT, which is 3 or 4, we know that a wound is not going to heal and we need to do some work to open up those blood vessels. But I think this is where it was really important for Dr. Fernando is, you see these patients with diabetic foot ulcers. And that ABI blood pressure test in the past was false. And now he has a tool to ultrasound the blood flow or the arteries around the diabetic foot ulcer and say, the flow is good. Let's just optimize the patient on medication, wound healing, offloading, or maybe the blood flow is bad and now the patient needs to have surgery to open up more blood vessels.
And Dr. Fernando, there in El Salvador, are you able to open up with wires and balloons those small vessels in the foot that are blocked up and going to the wound? Are you serious?
Yes, but only in the private practice, and it's too expensive. That was the project that we started 11 years ago with my colleague, Dr. Marco Fuentes, who is the one to perform the angioplasty. Try to get low cost as easy possible to our patient to perform the angioplastic and can open the little tiny. We have 0.3 millimeters catheters and balloons to do it, the angioplastic.
So Kym, his partner is an interventional radiologist, and Dr. Constantino and I went to El Salvador. I think that was 2023, right, Fernando?
Yeah, 2 years ago.
Yeah. So Dr. Constantino and I went down there and we actually did a case all together. And Dr. Fernando and I were down at the foot, monitoring the PAT, and Dr. Fuentes and Dr. Constantino were doing the procedure. And all together, we did this really nice case, opening up the blocked artery, and we saw an improvement of PAT. And it was a really lovely experience, and I can't wait to go back.
No, and you know what is amazing? When we in the OR, the team working together, after they perform the angioplastic, you can measure with the PIT Doppler and see the difference after the angioplastic and before the angioplastic.
I mean, bring me back to that moment, Dr. Fernando, where you actually, for the first time, were literally with the Doppler experiencing this real-time perfusion of the foot based on someone going in with wires and balloons performing angioplasty, where the balloon dilates. That's what angioplasty is, to push the plaque aside to clear up the blocked roadway and allow the traffic to flow through, the blood flow to get through. What was that like for you? Did everyone just erupt in cheers? Did you have tears? I know that rhymes.
No, it's kind of amazing because after that, perform the angioplastic, but you not be so sure that if you perform in the OR, it's okay to have the wound healing. So right now with the PIT Doppler, you are 100% sure that if you perform a very good angioplastic, the wound healing is going to be excellent in that patient. It's kind of amazing because you see all that foot that all the people only say, no, they're going to need a major amputation. But after a very good treatment of the wound healing after the angioplastic, you see in 3 months, 4 months at most, the wound healing completely closed.
And in the last quick 30 seconds here, I just want to explain to people, and maybe you could just do it. Why is blood flow so important for wound healing?
Without no blood flow, it's not going to heal the ulcer.
There's no oxygen, there are no nutrients getting to it. It's basically starving the tissue of any nutrition.
I always say my patient there is 2 ways that they are going to end in a major amputation, because we cannot control the infection or because we don't have enough blood flow in the foot.
And coming up right here on the Heart of Innovation, we're going to have more with Dr. Fernando and vascular technologist Jill Sommerset, my guest co-host for the day. So stay with us. Don't go away. You're listening to KDOW in the Heart of Innovation.
3 years ago, my symptoms started with leg
Awesome.
pain.
That was fantastic. I'd love to, go into how, I mean, now that you've done this, you must be so excited to share, but it's only available to people through privates. They have to have the cash in order to be able to do it.
Yes, but that's why every 2 years we do in our Congress in El Salvador, Jill come to our country for the workshop for most of like 25 or 30 colleagues that learn the technique. Most of the colleagues is in the institutional hospital. So the only thing is that we have to convince them the useful of the PIT Doppler.
I mean, it's, well, not only that, but to be able to open up arteries in the foot, that must just kill you when you see someone that comes to your clinic still and they've already had one leg chopped off and they're on deck for another. And you're like, gosh, I could have saved the other leg.
Yeah, it's kind of difficult because they don't perform angioplastic in the national hospital, only in the private practice here in El Salvador. So when you cannot afford it, do any major amputation. That's the sad thing of this.
So Kym, though, I want to, I'm going to WhatsApp you this. The diabetic foot wounds that he's dealing with are significant. And the fact that the pre and post images, here, let me just send this in the chat. It's just really amazing, the incredible work that he's doing and saving these limbs when otherwise they probably would have been amputated.
So why don't you take us back? Why don't you take us back? Just, hey, I'm Jill Sommerset in for Dr. Phillips. We're talking to Dr. Fernando, and then go into that with him.
Okay.
That'll be fun. And doctor says, have a great show. I'm in the air.
I'm training his techs, Kym, soon.
You're going back over there?
I'm going to do it just virtually.
Oh, Lord Almighty. Oh, Lord. Wow. Yeah.
Yeah, do you see that?
Yeah, those are significant. And, the thing is also we should get into what education is being done across El Salvador, because, I'm curious in different, is diabetes a problem there because
30
of
seconds.
lack, the socioeconomics, or is it people are just literally eating, lots of carbs, like boys, because of general diet?
That's the major problem, the diet.
But is that more because of socioeconomics?
Maybe the two factor, the socioeconomic and the diet.
1220 KDOW.
Jill's up.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kym McNicholas and interventional cardiologist Dr. John Phillips.
Welcome back, everyone. Thanks again for tuning in. I'm here with Dr. Fernando Irigoyen from El Salvador, and thank you, Kym, for the invitation for us to be here and share, all of the great work that he's doing in El Salvador. But I really just want to highlight, him and I go back and forth on WhatsApp, and we've known each other, for 6 years. And, he shares these pictures of these patients that arrive in his clinic with significant wounds of these diabetic foot ulcers. And he's using this technique called pedal acceleration time, or ultrasound of the foot, to measure the blood flow. And, in the past, Dr. Irigoyen, you would assess the diabetic foot ulcer, do an ABI, and that would be false. and you weren't sure if there was enough blood flow, and perhaps that patient went on to amputation. But after we met in the pandemic and I trained you, now your algorithm of saving these diabetic feet is a bit different. Can you speak to, let's say a patient arrives into your clinic with a significant diabetic foot wound. Now, what is your plan?
First of all, I always say to all the colleagues that you have to sit with the patient and make to be the friend of the patient. All the diabetic patients that came to us are afraid because all the colleagues said that they need a major amputation. And when they hear a different evaluation, they hear there is something that you can do to avoid that, the face of our patient changed. And I try to explain them that we are going to perform the evaluation to know how is the infection and how is the flow of the foot. So I explained that we are going to try to measure a little tiny artery on the foot, and the plan of the pedal acceleration time is not to get a worse pedal acceleration time. I say that like a school, I need to pass the test, not to fail the test. So I take my time to perform the PIT Doppler. Yeah, at the beginning, take me 1 hour to perform. Right now, I perform in 15 minutes. So it's easy to do it when you got the skill to perform. So when I show the patient without no measure, and I say that here is your trouble, we have to fix them with an angioplastic, and then we perform the angioplastic and perform again the PIT Doppler, and they listen the sound of the PIT Doppler. You don't imagine the face of the patient and the family when they say, so the foot is going to be safe. I hope so.
Because can you also speak to your medical optimization with these patients? What kind of medication do you put them on? What's their wound healing? What's your plan?
Yeah, and that's the point, that most of the diabetic foot only think that we're going to give them antibiotics to heal the wound. And it's not only that we are going to give them, we anticoagulate most of our patients, trying to explain them what is going to be happen if they don't take the pills for the anticoagulation in the proper way, because I know that they are afraid that make a bleed of the brain or make a bleed of the stomach, but I try to explain them that it's going to need that medication, and if they take in the proper way and how we indicated the treatment, there's going to be no anything wrong to take that. Maybe the worst patient that we have is the patient with a kidney failure. When they have the kidney, most of the patient and in a major amputation. Even we perform the best angioplasty, the best treatment, as the worst patient that we have, that's that.
Yeah, the chronic kidney disease patients also, just like diabetics, get a lot of below the knee disease. But what is really tough about a chronic kidney disease patient is that they can't tolerate the contrast fluid that is required for these procedures for angioplasty to be able to open up the arteries. And I would imagine there in El Salvador, you don't have the alternative CO2 to use on them. But there are a lot of doctors out here that are also using external ultrasound to help them in these types of procedures. And you're nodding your head. You try to do those when you can as well.
Yeah, we cannot be able to use a lot of contrast to perform the angioplastic. We help with the ultrasound.
And just to go back, Dr. Fernando, so you put your patients on a anticoagulation. Do you also do a statin?
Yes, we put anticoagulation, antibiotic, an advanced wound healing. When we can't, we use anti-inflammatories, but only the kidneys is allowed us to use it. And sometimes we try to treat the venous problem too, because right now that's what I saw, that it's a mixed problem. Not only remember that the very foot pass 3, 4, 5 months without no walking. So the venous problem, and sometimes we have a mixed problem in this patient. So it's very important to see if the ulcer is not only for diabetic, it is a venous problem too. So we have a different approach to this patient.
And before we go to break, I just want to ask about, do you offer them here? It's a big deal, Ozempic and Jardiance and Wegovy, all these diabetes drugs. Do you have any drugs there that lower the A1C?
No, it's not available here, but most of our patients be treated with oral treatment or insulin, but they have to inject every day. That's the problem, because there are a lot of medication that it'd be useful in this patient. We don't have it in El Salvador.
And coming up right here on the Heart of Innovation on KDOW, we'll have more with Dr. Fernando and Jill Sommerset, our guest co-host of the day. So stay with us. Don't go away.
That was lovely.
Yes.
So, Dr.
This is our
Fernando,
last,
sorry.
I think this is a 9-minute segment. So it's a nice long segment again. But this is our final long segment, and then we'll have a 4-minute segment where will do takeaways and learnings and more to come. Go ahead. What were you going to say?
Oh, well, I was just going to also share that he speaks all around the world, Italy, Russia. I mean, he goes everywhere talking about the use of PAT in diabetic foot and also in the treatment of mixed disease. Like he was just talking about venous disease. So these patients who have a venous ulcer, they also could have underlying arterial disease. So I think it's worth noting, like he throws everything at these patients with venous disease, looking at the PAT Doppler to make sure that the arterial status is also okay. But he is globally recognized, and the work he's doing is really extraordinary.
Yeah, and I'm curious about how you are expanding your work and influencing other doctors across not only El Salvador, but in these other countries. And I'm curious about the resistance that you face, because I know Jill even here faces resistance, and it's so frustrating. And I have to bite my tongue sometimes when doctors argue for their own limitations. And of course, they don't need anything they don't have, which if we don't have a cure for PAD and these diabetic wounds, then why do we still have a problem? Why are your patients still not healing? Like, I just don't understand. Why do you not have solid outcomes? Why do you have a revolving door treatment with these patients where you're not even doing these treatments because there is a revolving door? Well, maybe the difference could be PAT.
Yeah, I mean, I train a lot of physicians outside of the United States right now. I'm training one in India, Ecuador, and Poland, and they're much more amenable to learning new techniques than the US. But I'm slowly making headway in the United States.
Yeah, absolutely. We just, and you're doing it in great ways. I mean, I love seeing when they put you on podium up there. I think that's huge. You typically, you know, see a certain number of doctors up there, and you very rarely see anyone but. And it's so nice to see you on podium around the world.
Thank you.
You're so dynamic up there. It's so amazing how, you just like this contagious energy. You can just feel, and like, I know Jill's on stage in the other room. Like, I can still feel the energy next door.
That's so nice. I mean, don't you think, Fernando, we love what we do, and the fact that we have something that I think can change outcomes and impact patients' lives, I think is really extraordinary. So I think we want to spread the message and teach as much as we can. And
that's what we want to do, to express and try to more colleagues understand that there are a lot of techniques that can improve our work and that get better in the very patient. You know that after PAT, the PAT Doppler, I used to make 1 or 2 major amputation a month. Right now, in this year, only 1.
Isn't that amazing? See?
Oh, we need to talk about that on the show. And Douglas was also mentioning, because we kind of skirted around, the fact that you kind of had this epiphany or this aha a moment where you realized you needed to do this. But was there a specific situation? Was there a specific patient that you just got fed up and you were like, okay, after this patient, I just can't do this anymore. There's got to be a better way. Was there a specific patient or a grouping of patients over the course of a number of days?
The way that we look for another technique is because when we perform in the ABI, we start looking that sometimes we don't able to measure, and other times it's higher. So we start doing arterial plethysmography. We buy the equipment. We learn how to do arterial plethysmography, but arterial plethysmography is not very specific. Where is the trouble? So we start looking for more. That's where I love the IT Doppler, because you can see where the trouble is and what you
30
have
seconds.
to fix.
But you could have just gotten a regular Doppler ultrasound and done regular. I mean, why did you go to the extra mile to do PAT when we can? We struggle to get even doctors to do that here.
Very high humidity will be the norm in the coming days. 3 people are.
I always say in my talk, as a phlebology, I have the ultrasound in my clinic. So add another.
AM 1220 KDOW.
It's
Sorry.
easy.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kym McNicholas and interventional cardiologist Dr. John Phillips.
Welcome back to the show. Dr. Phillips has the day off, and vascular technologist, world-renowned vascular technologist Jill Sommerset is here as my guest co-host. Very lucky to have her and her friend from El Salvador. He's a general surgeon. It's Dr. Fernando Irigoyen. I got it that time. I'm learning how to roll my R's a little bit better. My Spanish teacher would be so happy, Mr. Lozano. So happy to have you here. You're making such a difference in terms of the lives and limbs of patients over in El Salvador, in taking time to say, hey, you know what? I don't like the way things are done here. I don't like my limitations. I'm not going to argue for my limitations. Instead, I'm going to find a solution. I can't save all the limbs that I want to save of patients who have poor circulation in their feet and in their legs, whether it's arteries or venous, their veins. I got to do something about this. And you did. And you brought Jill and also her friend and her colleague, Mary Costantino, who's an interventional radiologist. You brought them over to El Salvador and they taught you some new tips and tricks in order to save limbs. And since implementing, especially the pedal acceleration time, where you could measure that perfusion clear into the smallest arteries in the toes in real time, what tangible impact has this had on reducing amputations in your area of El Salvador, or at the very least in your practice?
You know that 5 years ago, maybe we perform 2 major amputations a month, every month, a lot of amputation in my private practice, okay? But right now, doing a very good vascular evaluation in the patient, because we not only perform if we have a diabetic foot, we now start performing the IT Doppler in diabetic patient, because we have to prevent, and we can see if they have a mild ischemia, for example, a PIT Doppler 2, we start treat them before they get a diabetic foot. So right now, we only perform in this year 1 major amputation.
It's so far in 2025, only 1.
Only 1. And we have more patients than 5 years ago.
So what impact has this had on influencing other physicians and even hospital administrators and possibly the government and who runs the public hospitals to implement a technique like this and to go the extra mile for these patients to save their legs? Because an amputation is not only a cost of a limb on the patient, right? But it literally has a huge burden financially and socially on our entire society.
I think, first of all, is the ego.
Oh, no.
Our doctors, I think, when you say you have to perform a ultrasound, go to the radiology. I'm a surgeon. I only perform the surgery, they perform that. So I think it's the ego. That's why it's kind of difficult to implement in most of the country.
But couldn't radiology adopt this practice and pair up with these surgeons in order to improve the outcomes? I mean, that could be an answer, right?
Yeah. That's what we are working on that. And every time I be in the stage or in the podium, I try to explain with the colleagues what the PIT Doppler helped me a lot in these 5 years to improve my treatment in the very patient.
So you actually speak across the globe. Where do you feel that you've had the greatest influence in speaking to doctors and getting them to adopt your way of thinking and your tools and your techniques that you have learned along this journey since meeting Jill and Mary Constantino?
Maybe in Italy, a lot of radiology come to me and say, can I have the name of the creator of the PIT Doppler? Because it's very interesting, the technique that you present right now. So I think when they saw the how the PIT Doppler can help us, and how you see because it's not only to make the first evaluation in our patient, it helps us in the OR after the angioplasty and help us after the angioplasty to make the control of our patient if they are still open at the artery. So in Italy, I think is the most very, very interesting in the technique.
Fantastic. Well, coming up right here on the Heart of Innovation, we'll have final thoughts from both Dr. Fernando Irigoyen and vascular technologist Jill Sommerset, my guest co-host for the day. So don't go away. You're listening to KDOW on the Heart of Innovation. Switch that. The Heart of Innovation on KDOW. That was awesome.
Hey, Doug, to answer your question, he was just asking why doctors in the States are reluctant. The doctors actually aren't. It's translating the information, teaching the vascular ultrasound techs to do the test. We have a national shortage of ultrasound techs who are overworked. They're still required to do the ABI test. So by the time they're given 20 patients a day with the ABI test that doesn't work, and they do the ultrasound, by the time they get to the foot, they're out of time. So I'm trying to change how we are approaching these patients. I'm trying to teach that they need to start ultrasound at the foot first in the diabetic patient, right? Because Dr. Fernando and I really agree that when you start at the foot, you already know what the blood flow is like. You've already answered the question, is it good or bad?
If you have flow in the toe, where the blood come from? If you don't have it, yeah, we go upper and see where is the problem. But
go after it.
I don't know. They perform a lot of Doppler, artery Doppler, but just finish at the leg, and it's at the very foot. They don't.
That's what I don't understand.
Yeah,
I have so many patients in England. We got to get this more across England as well. when they stop at the ankle and they're like, oh, you're fine. But it's in these diabetic patients. We have patients that literally have okay blood flow clear up until they hit the foot, and their foot is just a mess. And, maybe I'm not sure what you want to cover in just the last few minutes that we have. But one of the things is what people don't realize with diabetes is not only do the sugar molecules scratch the arteries leading to the inflammatory response and the plaque buildup, et cetera, right? But secondarily, it makes your blood thick and sticky. And that's why it can't get through those really small vessels as well. And so I would imagine that nutrition has to be a part of it. I would imagine that you'd have to have the conversation with these patients on their diet, correct?
They change after we save the food. They change their diet because they realize that what we eat is the cause of the diabetic foot, and the most meal in El Salvador are carbs.
Oh no! Is that just by culture? Or is that
by culture? Yeah.
But it's
Latin
really
America is carbs.
Oh, I bet it's probably delicious.
Oh, good.
As Jill. She already tried.
30 seconds.
So what do we want to cover in the last 4 minutes?
What about any advice from Dr. Fernando about how, if someone wanted to start this in their practice, what would you say? What's your advice? They can call me, but they can call you. You can teach.
That'd be fun. Maybe the help from patients to ask their doctors about it, like Susan G. Komen was all about
1220 KDOW.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kym McNicholas and interventional cardiologist Dr. John Phillips.
Hi, everyone. Welcome back to the show. We're rounding third, headed for home, as Dr. John Phillips would always say. Except he's off saving those piggies. He'll be back next week. But we're honored to have our guest co-host for the day, vascular technologist Jill Sommerset, and her friend, Dr. Fernando Irigoyen. And we're talking about pedal acceleration time. It has been a game-changing technique for Dr. Fernando and his practice, reducing amputations from 2 a month, major amputations from 2 a month to literally only 1 in 2025. Absolutely amazing. And now he is traveling the world trying to spread the message on the impact of pedal acceleration time, or PAT, which was developed by Jill Sommerset. And I'm curious, from your perspective, Fernando, if anyone is interested after listening to the show, like, what advice would you have on bringing this into your practice or their practice?
Like I said at the beginning, I start doing PIT Doppler via Zoom. And when the airport opened, the first flight I took was for Oregon to meet Jill in person and try to myself to improve the PIT Doppler technique. So right now, for example, we have our Congress, the very Congress, this year. We are going to perform a workshop that Jill is going to be here to teach all the people that want to know the technique. So I think to learn is very easy. You only have to have the how to say it in English, en español se dicen las ganas, that you want to do it. If you want to learn, you can learn. It is not difficult to learn. I learned PIT Doppler in 3 months. Doing every day. Yeah.
Oh, doing it every day.
Because we have a lot of patients in our clinic. So more you do it, it's more easy to perform. Like I say at the beginning, it took me 1 hour to perform. Right now, I perform in a diabetic foot in 15 minutes, because in not diabetic, you do it in 3.
Yeah. But along with having that, they have to be willing to do something. So you get the information, and maybe it's just like they turn a blind eye and don't want to do it because they don't have the ability to be able to take those wires and balloons and do something about it, get into those small arteries and try to open them up. We still have that issue across the globe where doctors are still slow to learn the skill of opening up those small arteries, in the foot, because for many people, it's not durable. But the whole key is if you can give them just a little bit more blood flow, get their diet under control, get them on the right meds, you can get them walking to grow their own natural bypasses, which is really key. So, final thoughts, Jill Sommerset, my amazing co-host. Amazing. We started with amazing. We're going to end with amazing.
Well, thank you. There's a lot of published literature. There's I think YouTube videos. You can attend conferences to learn more about it, and certainly always feel free to reach out. I think we're trying to teach as much as possible and continue to do the research. And so I guess that would be my advice is feel free to reach out anytime, Kym.
And just in the last 15 seconds here, Jill, I mean, what was your reaction in hearing one amputation down in the entire year so far, down from 2 per month?
I mean, I think it's pretty extraordinary. It speaks to his dedication to reduce amputation in El Salvador. But I think it gives us hope for patients to save their limbs.
You've been listening to The Heart of Innovation with Emmy Award-winning journalist Kym McNicholas and interventional cardiologist Dr. John Phillips.
And Jill, if you want to just quickly finish your thought, I'll edit it into the show for you, into the recorded version.
Okay. And I want to say thank you to Dr. Irigoyen and you, Kym, for allowing us to share this story and continue the great work that he's doing in El Salvador and the great work that you're doing as well.